mendengar 3 kata itu, begitu banyak pertanyaan yang muncul di kepalaku. Tak terbayang akan bagaimana hidupku ke depannya.
Kanker multiple myeloma. Istriku, anakku, pekerjaanku, yang hadir hanya pikiran buruk. Akan kehilangan semuanya.
Semua rencana-rencana yang aku bangun menjadi tidak pasti. 3 kata itu berubah menjadi 1 kata. Takut.
Saat ini, untuk melangkah pun terasa berat. Bagaimana aku bisa menghadapinya?
Tidak, aku tidak akan menyerah.
Semangat, Bu.
Begitu banyak dukungan dari orang-orang sekitarku. Masih banyak rencana yang ingin kujalani. Aku harus bisa.
Aku harus bangkit. Ya, bangkit. Karena selalu ada yang hadir memberi semangat.
Kujalani semua pengobatan dan terapi yang tidak pernah terbayangkan sebelumnya. Progres demi progres membangun semangat dalam diri ini. Walaupun ada proses yang harus dijalani. Ayo Nuri, kamu pasti bisa menghadapi ini.
Pak, sepertinya Ibu sudah sadar. Lekas sembuh ya.
Bisa melihat keluarga dan sahabat memberiku semangat untuk segera sembuh dan melakukan banyak hal dengan mereka lagi, serta kembali beraktivitas seperti dulu.
Dimakan dulu ya, Pak, sarapannya.
Ternyata harapan itu selalu ada.
Harapan selalu hadir setiap kali aku mulai putus asa.
Dan akhirnya aku bisa berkata, Nuri, kamu sudah bebas. Bebas menjalani rencana-rencana, bebas berbagi dan menyebarkan semangat untuk mereka yang tengah berjuang.
Saat membaca hasil lab dari dokter, aku mengucap syukur pada Tuhan. Karena sekarang aku bisa melangkah lagi, merasa seperti hidup kembali. Bahkan sekarang, sudah bisa beraktivitas lagi.
Integrated CT Linac has been installed at MRCCC Siloam Semanggi, leading the future of radiotherapy for a better healing journey. Developed by United Imaging, Changzhou, China, the integrated CT Linac incorporates artificial intelligence within the system, enabling the integration of high-resolution imaging and advanced engineering to enhance accuracy, innovation, and clinical expertise. A collaboration that transcends borders, built to support individualized, high-precision cancer treatment. Each stage has been meticulously planned to reach MRCCC Siloam Semanggi, Jakarta, Indonesia. A comprehensive cancer center where innovation aligns with technical mastery to enable efficient workflows and faster treatments. Introducing Integrated CT Linac, where advanced precision meets seamless care. Integrated CT Linac is an advanced radiotherapy technology that combines high-resolution diagnostic CT imaging and a linear accelerator within a single system. The system features a large extended field of view of 50 to 87 centimeters with a scan length of up to 100 centimeters, enabling comprehensive anatomical coverage. In conventional Linac systems, imaging is typically performed using cone beam CT, while CT Linac integrates diagnostic quality fan beam CT imaging to support wider coverage and clearer anatomical visualization during treatment. This integrated approach allows imaging, treatment planning, adaptation, and radiation delivery to be performed in one seamless session without repositioning the patient. With the support of artificial intelligence, the entire process can be completed within 15 to 25 minutes, significantly reducing preparation time compared to conventional radiotherapy workflows. Integrated CT Linac is equipped with adaptive radiotherapy, enabling treatment plans to be adjusted daily based on the patient's anatomical changes. This ensures precise radiation delivery to the tumor while minimizing exposure to surrounding healthy tissues. At MRCCC Siloam Semanggi, integrated CT Linac supports a more personalized, efficient, and patient-centered radiotherapy experience.
This installation helps expand treatment options locally, allowing patients to receive complex care closer to home with the support of their families. At the same time, we are very conscious that meaningful patient benefit does not come from installation alone. It comes from careful clinical integration, strong governance, and continuous learning. We see the system as a foundation for that process rather than a final achievement.
This machine can treat the very small tumor until the huge tumor, and also to push the boundary of the precise radiotherapy and the best personalized cancer experience to every patient.
Selain itu, inovasi ikut berperan penting dalam peningkatan perawatan pasien, mencakup kemajuan dalam modalitas diagnostik dan terapeutik yang memungkinkan pelayanan kanker menjadi lebih presisi dan personalized. Hadirnya Integrated CT Linac merupakan sebuah kemajuan signifikan bagi pasien kanker karena memungkinkan terapi yang lebih presisi dan efektif.
MRCCC Siloam Semanggi welcomes a new benchmark in cancer treatment designed for confidence, efficiency, and patient comfort.
Selamat datang di MRCCC Siloam Hospital Semanggi atau The Building of Hope. Sejak didirikan pada tahun 2011, MRCCC telah berdedikasi untuk memberikan layanan kanker terbaik, menjadi simbol harapan bagi setiap pasien yang melangkah masuk ke dalam rumah sakit ini.
Didorong oleh tujuan untuk mewujudkan misi tersebut, komitmen MRCCC sebagai rumah sakit kanker terkemuka telah mendapatkan pengakuan baik di tingkat nasional maupun internasional. MRCCC dengan bangga tercatat sebagai salah satu rumah sakit spesialis onkologi terbaik di Asia Pasifik versi Newsweek dan meraih penghargaan Healthcare Asia Award sebagai Specialty Hospital of the Year 2025. MRCCC juga terakreditasi oleh Joint Commission International dan dianugerahi Asia Best Employer Brand Award. Di Indonesia, MRCCC masuk dalam daftar 10 besar rumah sakit onkologi terbaik versi Perhimpunan Rumah Sakit Seluruh Indonesia (Persi), serta meraih akreditasi paripurna, standar tertinggi untuk rumah sakit di Indonesia. Untuk memberikan layanan yang terbaik bagi pasien kami, MRCCC juga menjalin kerjasama dengan institusi kanker terkemuka dunia, termasuk Netherlands Cancer Institute, Asan Medical Center, Japan's National Center for Global Health and Medicine, National Cancer Center Singapore, dan National University Hospital Singapore. Selain menjalin beberapa kolaborasi tersebut, MRCCC juga terus mengembangkan program klinis di bawah naungan MD Anderson Cancer Center. Hubungan ini memperkenalkan standar global dalam perawatan kanker di Indonesia. Di MRCCC, kami menerapkan pendekatan perawatan multidisiplin para spesialis onkologi medis dan bedah, patologi, kedokteran nuklir, radiologi, serta disiplin ilmu lainnya bekerja sama untuk memberikan perencanaan pengobatan yang dipersonalisasi. Pendekatan ini diterapkan ke semua pusat keunggulan kami yang mengutamakan penanganan berbagai jenis kanker. Breast Cancer Care Alliance, Gastrointestinal Cancer Center, Gynecologic Oncology Center, Lung Cancer Center, dan Hematology Malignancy Center, masing-masing dipimpin oleh tim ahli serta didukung oleh teknologi terkini untuk memastikan penanganan yang tepat, inovatif, dan mengedepankan kenyamanan pasien. Breast Cancer Care Alliance menyediakan layanan same-day biopsi dan teknologi biopsi vakum untuk diagnosis yang akurat, serta layanan rekonstruksi payudara untuk mengembalikan kepercayaan diri pasien. Gastrointestinal Cancer Center menghadirkan teknologi mutakhir seperti liver elastography, endoscopic ultrasound, dan radiofrequency ablation untuk diagnosa dan langkah intervensi yang akurat. Lung Cancer Center menyediakan pemeriksaan low-dose CT scan dan endobronchial ultrasound untuk mendeteksi kanker paru sejak dini dengan hasil yang akurat. Gynecologic Oncology Center menawarkan perawatan minimal invasi seperti brachytherapy dan cryoterapi yang dirancang untuk menciptakan rasa nyaman serta mengoptimalkan proses pemulihan. Di Hematology Malignancy Center, kami menyediakan layanan transplantasi sumsum tulang dalam ruang isolasi canggih dan steril untuk melindungi pasien dengan imunitas rendah. Untuk melengkapi program, MRCCC juga menyediakan layanan menyeluruh di bidang laboratorium, kedokteran nuklir, dan terapi radiasi. Untuk memastikan diagnosis yang akurat, MRCCC memiliki pusat laboratorium yang lengkap untuk patologi, immunohistochemistry, dan diagnostik molekuler. Departemen Kedokteran Nuklir MRCCC dilengkapi dengan spek CT dan PET CT scanner, serta fasilitas radiopharmaceutical in-house, termasuk siklotron untuk memproduksi isotop yang dibutuhkan dalam diagnosis dan pengobatan kanker. Isotop ini diberikan menggunakan alat injeksi otomatis yang memastikan dosis tepat untuk keamanan pasien. Terapi target MRCCC mencakup lutetium PSMA untuk kanker prostat dan ablasi tiroid yang dilakukan di ruang isolasi radiasi. Layanan radioterapi kami menggunakan teknologi linear accelerator untuk terapi radiasi eksternal, brachyterapi untuk radiasi internal, serta CT simulator untuk memastikan setiap pasien mendapatkan perawatan radiasi yang tepat sasaran.
Di MRCCC, perjuangan kami melawan kanker tidak hanya sebatas pengobatan klinis. Kami juga menawarkan dukungan menyeluruh melalui layanan perawatan paliatif dan berbagai kegiatan dengan komunitas penyintas kanker.
Kami berkomitmen untuk terus berkembang, selalu berupaya memberikan perawatan terbaik dan memenuhi kebutuhan pasien.
Di MRCCC, kami mengantar Anda kembali pada hal-hal yang berarti.
Every day, more than 30 lives are scanned, served, and treated, trusted by more than 43,000 patients throughout their diagnostic and treatment journey. We deliver precision in molecular imaging and therapy since 2011. At MRCCC, we utilize PET-CT and SPECT technologies to visualize what's invisible to the eye, capturing molecular activity even before structural changes occur. With just one scan, we deliver results within a day, providing clinicians with the clarity to act swiftly. Every image is interpreted by a dedicated team of nuclear medicine specialists and radiopharmacists. Powered by our in-house cyclotron, we independently produce radio tracers, ensuring an uninterrupted supply and consistent quality. Our key innovations are PET-FDG, Brain PET, and our latest addition, Gallium PSMA, a molecular tracer for prostate cancer detection, known for its high specificity and sensitivity. At MRCCC, PET scans are available daily, with results delivered within one day, made possible by our in-house synthesis capabilities. PSMA molecule used in imaging can also be linked to therapeutic lutetium radioisotopes, forming a direct bridge between diagnosis and treatment for prostate cancer patients. The radiotracer injection process is further optimized by our autoinjector, which standardizes dose delivery, minimizes variability, and enhances patient safety. Interpreting a PET scan is a complex process that requires collaboration. Our nuclear medicine doctors work closely with other specialists during multidisciplinary tumor board meetings to determine cancer staging and guide treatment planning. This collaborative team play a crucial role in these discussions, helping the team make informed and confident decisions for each patient's care. For therapies, we go beyond detection, delivering targeted treatments through radioiodine ablation for thyroid cancer, lutetium dotate for neuroendocrine tumor, and samarium for cancer pain management. This reflects our commitment to not only identify diseases, but also intervene directly using nuclear medicine. Through our partnership with Antonie van Leeuwenhoek, Netherlands Cancer Institute, we align with world-class standards and gain access to global cancer expertise. This collaboration ensures that MRCCC's practices meet international benchmarks, supported by expert consultations on complex cancer cases. At MRCCC Siloam Semangi's nuclear department, we don't just scan, we illuminate, guide, and personalize every step of the cancer care journey. For us, nuclear medicine is more than a service. It's a vital part of how we help patients move forward, with clarity, precision, and confidence.
Hi, Celia. Back again for your yearly check?
Hi, Nurse Melissa, Dr. Becca.
Welcome to BCCA. Here, your journey is ours too. If you ever need anything, we're always ready for you. Today we'll start with a mammography and an ultrasound.
For now, just relax and breathe. You're in good hands.
Are you nervous? That's okay. Getting checked can feel scary. But remember, early detection saves lives, and that's what matters.
Is something wrong?
We found a mass in your scan. Let's do a biopsy to get a more accurate diagnosis.
Suddenly, my mind was somewhere else entirely, lost inside my own body. Just stay positive. It's probably nothing. But what if... No, don't think like that. You're worrying too much.
Celia, unfortunately, I have some difficult news. The biopsy results show that you have breast cancer. The good news is we caught it early.
What's going to happen
So
to
let's
me now?
treatment immediately.
What about everything I have?
Breast cancer.
I'll never be whole
You
again.
have breast cancer.
Who will look after my family? What am I going to look like?
We are here for you, Celia. You're not alone.
If it feels scary, maybe it's because we think we have to walk this journey on our own. A hand to hold, a shared laugh, a circle of support. These are the things that remind me that I'm still me and that I can feel whole again. Now, I'm no longer afraid because I know that I'm at the right place, surrounded by the right people, being given the right care. And for now, that's what matters most, as I take one step at a time.
Ready to see your results?
distinguished speakers, our valued partners from United Imaging Healthcare, respected physicians, healthcare professionals, and all participants joining us here at MRCCC Siloam Semanggi, as well as those tuning in live through our YouTube channel at MRCCC Siloam Semanggi. My name is Joanna, and I will be your host today. It is my great pleasure to welcome you to the Advanced CTO Masterclass 2026, proudly presented through the collaboration between MRCCC Siloam Semanggi and United Imaging Healthcare. Today, we are privileged to witness a live demonstration of one of the most technically demanding procedures in interventional cardiology, chronic total occlusion, CTO intervention, performed by an esteemed panel of experts alongside insightful discussions from our distinguished international faculty. Before we begin, please allow me to share a few housekeeping announcements. First, for both our on-site and online participants, we encourage you to submit your questions regarding today's procedure through the comments section. Our moderators will select questions throughout the session and raise them for discussion with our panel expert. Secondly, for those of us here joining on-site, if you would like to ask a question, kindly raise your hand, introduce yourself and your institution before directing your question to the moderators. As today's session is being live streamed, should you need to leave the room at any point, we kindly ask that you do so discreetly through the entrance located next to you. We would also appreciate it if you could keep your mobile phones and electronic devices on silent mode throughout the session. As we speak, our operating team is making their final preparations at the cath lab. And before the start of today's live procedure, it is my honor to invite Mr. Tris Nainggolan, Executive Director of MRCCC Siloam Semanggi, to deliver the opening remarks. Ladies and gentlemen, please join me in welcoming Mr. Tris Nainggolan.
A very good morning. Distinguished speakers, our valued partners from United Imaging Healthcare, respected physicians, healthcare professionals, and all participants joining us online, also on-site at MRCCC Siloam Semanggi. My name is Tris Nainggolan. I am the Executive Director of MRCCC Siloam Semanggi. It is very good to have you, to see you here, those who are joining us offline, and also those joining us online. It is my pleasure to welcome you to our hospital. Welcome to Jakarta for some of you, and also welcome to the Advanced CTO Masterclass 2026, proudly organized through the collaboration between MRCCC Siloam Semanggi and United Imaging Healthcare. It is an honor to be joined by our distinguished faculty today. Prof. Tan Hui Chim, who is joining us virtually at the moment. Prof, thank you for your time. Also joining us here on site, Prof. Lei Song from Fuwai Hospital, Beijing, China. Dr. Hong Miao, Dr. Jun Xiang, and also the leadership from United Imaging Healthcare. Thank you for being here, such an honor. Dr. Bahtiar, Dr. Syafiq, yang saya hormati Dr. Muhammad Yamin, Dr. Arif Sejati, Dr. Indah, Dr. Dita, dan juga Dr. Febrian. Ladies and gentlemen, Mohtar Riyadi Comprehensive Cancer Centers, part of Siloam International Hospital, is one of the largest and leading private comprehensive cancer hospitals in Indonesia. Since 2011, MRCCC has continued to grow as a center of excellence in oncology with international reputation. Here at MRCCC, we believe that delivering better patient care requires continuous innovation, collaboration, and lifelong learning. Driven by this commitment, today we are proud to host the Advanced CTO Masterclass 2026 in collaboration with United Imaging Healthcare. Today's masterclass also marks an important milestone for MRCCC as our first international live case transmission and educational program broadcast across Southeast Asia. I was informed last night that this is also the first one for United Imaging to broadcast something like this across Southeast Asia. So it's a privilege to be able to do that together, Doc. Through this initiative, we're extending knowledge, sharing beyond this venue, and connecting physicians and healthcare professionals across the region, reinforcing our commitment to medical education and international collaboration. As a leading cancer center, we recognize that many cancer patients have a higher risk of developing cardiovascular disease, whether due to shared risk factors or the effects of cancer treatment. This makes collaboration between oncology and cardiovascular specialists increasingly important in supporting the best possible treatment outcomes. Coronary chronic total occlusion, or CTO, remains one of the most challenging conditions in interventional cardiology. Successfully treating CTO requires not only advanced technology, but also clinical expertise in decision-making and strong multidisciplinary collaboration. This is what makes the Advanced CTO Masterclass especially meaningful. It brings together distinguished experts and healthcare professionals to exchange knowledge, share clinical experience, and explore the latest approach to managing complex CTO cases. As we begin, I encourage everyone to make the most of this opportunity to learn, exchange ideas, and connect with fellow healthcare professionals. My sincere appreciation goes to United Imaging Healthcare for this valuable collaboration, to our esteemed faculty for sharing their expertise, and to all physicians, healthcare professionals, and guests joining us today both on-site and online. I do hope that today's discussion provides valuable insights and reflect our shared commitment to advancing cardiovascular care. Thank you once again for being part of the Advanced CTO Masterclass 2026. Good morning and have a wonderful day. Thank you.
Thank you very much, Mr. Tris, for your inspiring remarks. Your message serves as a powerful reminder of MRCCC Siloam Semanggi's commitment to advancing cardiovascular and cancer care through innovation, collaboration, and excellence. It is now my pleasure to invite our esteemed partner from United Imaging Healthcare. Please join me in welcoming Dr. Hong Miao, President of Global Marketing, Shanghai United Imaging Healthcare Company Limited. Dr. Miao, the stage is yours.
Distinguished Professor Song Lei, expert from MRCCC, and Professor Tan Hua Qing, and all online colleagues, a very good morning. It's a great honor to join us at the MRCCC Hospital at Jakarta for this live, complex CTO intervention broadcast. For United Imaging, this event is more than a live surgery demo. It makes a key milestone for our global cardiovascular collaboration. We're glad to bring together Professor Song Lei from Fuwai Hospital, Beijing, China, and the MRCCC team to share clinical expertise and address most challenging CTO, coronary procedures. Our noise-free U-Angio Aviva angiographic system installed at MRCCC represents our strategic expansion in Southeast Asia. Beyond leading low noise imaging technical, we deliver full precision interventional solutions to help doctors improve patient care. We believe technical connects people. We aim to build a long-term academic exchange, training, and clinical collaboration platform between China and Southeast Asia for experts to jointly manage complex cases like CTO. This event is built on our solid partnership with the Fuwai Hospital in Beijing, China. Since we launched our joint R&D center in 2024, clinicians, scientists, and engineers from both parties joined together and co-developed innovative medical devices to solve unmet clinical needs. Today, live operation is a great showcase of our joint innovation results. Healthcare has no limits and borders. Guided by our mission, equal health for all, United Imaging will continue to cooperate with top global hospitals such as Fuwai Hospital and MRCCC to turn technical innovation into tangible clinical value. Moving forward, we will keep boosting international academic exchanges, physician trainings, and experience sharing. Last but not least, we wish Professor Song Lei and MRCCC team full success with today's CTO procedure, and wish this Academy Live event a great success. Thank you all, and enjoy today's program. Thank you.
Thank you, Dr. Miao, for sharing not only United Imaging Healthcare's vision for the future of medical imaging, but also your valuable insights into how technology continues to transform patient care around the world. At this point, it is my pleasure to introduce today's moderators. Our first moderator is Dr. Indah Sukmawati, SPJP Konsultan, FIHA FAPSC. Dr. Indah serves as a cardiologist at MRCCC Siloam Semanggi and Siloam Hospital's Lippo Village, while also serving as a lecturer at the Faculty of Medicine in Universitas Pelita Harapan. Joining her today is also Dr. Xiao Jie Josh Lin, Vice President of the X-ray Business Unit at United Imaging Healthcare. We are delighted to have not one, but two distinguished moderators leading today's discussion and guiding us through this highly anticipated live case. They will introduce today's operators, speakers, and expert panel before we begin the live procedure. Ladies and gentlemen, please join me in welcoming Dr. Indah Sukmawati and Dr. Xiaojie Josh Lin to the stage.
Thank you, Ms. Joanna, for the kind introduction. Next, it is our great pleasure to welcome our distinguished faculty, Professor Tan Hui Chim from National University Hut Center, Singapore, my mentor and teacher. We are honored to have him today in today's academic discussion. So ladies and gentlemen, wherever you are joining us from, please give Professor Tan a warm virtual round of applause as we invite him to deliver the opening remarks.
Thank you very much, Indah, for the kind introduction. I think it's a real pleasure to be participating in this inaugural meeting between MRCCC and United Imaging Technology. You know, this is actually not, I actually have visited MRCCC 10 years ago at the invitations of Mr. Mukhtar Riyadi to visit the outstanding infrastructure in the system in the hospital. And we were looking for collaborations between MRCCC and NUH at that time. And I also recalled visiting MRCCC not by car, but actually by an helicopter, landing on the helicopter pad on top of the building to visit the center. So it was an incredible, amazing experience with the shortest distance from airport to the to the city itself. Now, for someone who has grown up using Tagano projector system, which you may not know, before we used to project a cine angiographic film, the 35 millimeter one, onto a projector screen. And you can imagine how poor the quality of the images can be. But certainly over the years, we have looked at the progress and development of digital technology. And we now know that imaging is so important, particularly pronounced in very complex anatomy and very challenging PCI. So high quality images, as we all know, give us a valuable anatomical information. It helps us to develop our plan, our strategy. It improves our procedural precision, and hopefully, of course, to improve patient safety. As interventionists like you and I, we are always constantly looking out for better ways to see, understand, and treat coronary disease. And so today, I'm pleased to see how United Imaging Technology will be able to help us in its application in real-world practice and in very challenging PCI situations. So I'd like to thank United Imaging Technology for this opportunity and for supporting this educational initiative. And more importantly, to also thank all our operators and our faculties and our participants for coming onto this particular meeting. And I hope today's meeting will be both informative, will be interactive, and also will be stimulating so that we all can leave with new insights into better care for our patients and using this technology that is available to us. So let me wish all of you a very successful meeting. Thank you.
Thank you kindly, Prof. Tan, for that wonderful remarks. Now, next, let's introduce our outstanding panelists. We are honored to have here with us Dr. Muhammad Yamin, Spesialis Jantung Udara Konsultan. Please take your place on the stage, Dr. Yamin. Please give a round of applause for Dr. Muhammad Yamin.
We also have two renowned cardiologists from Malaysia who join us today. They are Dr. Khairul Shafiq Ibrahim from Cellgate Specialist Hospital Rawan, Malaysia. Please welcome to come to the stage. As well as Dr. Ahmad Bhatia, MD Razi from Cellgate Specialist Hospital Rawan, Malaysia. Welcome. In addition, we are privileged to welcome Dr. Jun Xiang from United Imaging as a CEO of X-ray Business Unit. Welcome. If you have any technical questions, please raise up to Dr. Jun Xiang. And any questions for clinical side, raise out to our clinician specialist from Malaysia, from Indonesia. So let's move to the live case.
Okay, so if we can have our two distinguished operators in today's live session, Prof. Lei Song and beliau, he is the director of the cath lab from Fuwai Hospital National Cardiovascular Center of China, and Dr. Arif Sejati, cardiologist from MRCCC Siloam Semanggi. Ladies and gentlemen, please join us to welcome our operators. Dr. Song and Dr. Arif, could you please greet our online and on-site attendees? Good morning, Dr. Arif and Dr. Song.
Good morning.
Good morning. Good morning.
We start here.
Okay.
And Angel first.
And you from the beginning.
Yeah. Thank you, the moderator and the panelists, and thank you for the intervention. And good morning, Professor Chen. And it's my first time to Indonesia, and very kindly thank you for your invitation. And my pleasure to do this live case. And this my colleagues today, Dr. Arif. And first, please let Dr. Arif to introduce the case information, please.
Okay, thank you. Good morning, everyone. We are honored to host you to see our first CTO live case. And this is our case today. This is a 34 years old gentleman who have previously triple disease with RCA CTO. He presented with angina, CCS2, and he had type 2 diabetes, controlled with the oral medication, high dyslipidemia, and obesity. Currently, he's taking the dual antiplatelet as well as diabetic medication and also bisoprolol and atorvastatin. His ECG is okay without any pathological Q, and his echo show normal cardiac chamber, normal LV kinetic with normal LVEF. Next slide, please. Okay, on 1 May, 2 months previously, he went to other hospital and did the angiogram. From there, this is the previous angiogram. You can see chief vessel disease. They attempted to open the RCA-CTO with antegrade via escalation. They used the Fielder XTA, Gaia 1, Gaia 3, but failed. So they moved to LAD. They put one stent on the LAD and one stent to the OM. After the procedure, the patient still have symptom. So he came to us to try to attempt the CTO PCI to RCA CTO. So that's the brief summary. I can maybe Dr. Songlei can explain what we have done in this last hour.
Let's see today's angel. First, please.
Thank you, Dr. Songlei. But before we head up to what actually has been done in the cath lab, after seeing this angiogram, can we ask Prof. Tan, if you're still with us, based on the angiogram and clinical presentation, what is your first impression? And what are the key anatomical features that would influence your treatment strategy for this case, Prof. Tan?
Thank you very much. I think this is obviously a complex triple vessel coronary artery disease here. And I think the source of the angina most likely comes from the LAD artery, which is also collateralizing the RCA. So not only is the RCA completely occluded, but we also have significant disease in the other two left coronary artery. So my take here is that I would revascularize the LAD and the circumflex first, and then go for the RCA as the last strategy here.
Yes,
I'm actually also looking at the images quality as I trying to learn from this United Imaging technology, and I'm quite amazed by the clarity of the images as well.
Okay, yes. Prof. Tan, from the previous procedure, I think they've done the LAD and circ, and today the target is for the RCA. So if we can have the angio before the procedure for today, Dr. Arif?
Yeah.
Yeah, this is the
this is the AP cranial view, and we can see the previous LADs and circ standing is good, and the distal RCA is occluded, and just between the distal RCA and distal bifurcation, we can see a clear PDA, and but PLA is not clear enough. And the next view.
Next.
And this is RAO cranial. We can see several septal channels could be used, but the distal vessel is not good enough. So we have interventional septal channel, but distal vessel bed is not good. So the ADR technique is not available for this case. Next. And this is next view, please. Next. And this RAO 30. Yeah, we can see the occluded segment is not so long, maybe 20 minutes to 30 minutes, not more than longer than 30 minutes, I think. But with calcium. Next. This RAO caudal. Next. Yeah, we can see the proximal cap of the CTO is not clear. It's a blunt tip. So, but the first they have tried using the Gaia next 1, 2, and a third, I think, but they go to the subminimal space. So this time, my strategy is first try the antegrade first, but not with long time. My first choice, first wear is XTA, and maybe then upgrade to PAD 200 because CTO's course is not clear. I think the PAD 200 is safe wear, cannot go to outside the vessel structure, I think. And if the anti-grade wear is not success, so we will move to the retrograde quickly, and because the septal channel is good. That's my strategy today. And I want to ask the grid panel, the panelists, that do you have some suggestion for this case?
Yes, we have today Dr. Yamin, Dr. Shafiq, and Dr. Jun, and Dr. Bahtiar also. Anyone want to comment on this case?
Thank you, Linda. So I think I'm also amazed by the clarity of the imaging produced by this new system, honestly. I think I'm agreeable with the strategy of the operators. So looking at the CTO itself, if we calculate the difficulty based on the G score, I think at least we got 2 G score here, considered as difficult CTO. I do agree that we may approach integrately by using escalating wire technique, integrated escalating wire technique. If necessary, we may need to also do a parallel using the double lumen catheter, whatever, and so see how it goes. Try maybe half an hour. If we fail, then we convert straight away to the retrograde approach. That's my opinion, Marina.
From the other panels, Dr. Shafiq?
Ivasnya nggak usah, itu pengukuran Ivasnya nggak usah. Dimatiin aja. Pengukurannya
difficult to tell the route. Maybe perhaps we can have a CT coronary angiogram prior to this attempt to have a look on the calcified burden as well as the actual route of the coronary artery RCAs. That would be my 2 cents for this case.
Joe, can we display the CT on screen?
Thank you very much. Yeah, we do have the CT scan.
Dr. Bahtiar, you want to comment on the case?
I actually agree with with the panelists and also Dr. Prof Lee, because I think if you can see there's some micro channel there, so I think it's wise to try to consider integrate approach first, and then like Dr. Yamin suggests, I think the most half an hour. If you cannot puncture the CTO cap, then we probably need to go retrogradely. That's all.
Dr. Song, if I may ask a question to you, before the index procedure, they use XTA wire Gaia 1 and 2 but failed. Can you give me the reasoning or your point of view on today you use XTA first, right? Also the same wire as before. If I'm
I don't believe the XTA will cross this lesion, but I want to test to feel the occlusion segment with the calcium and the structure, and then we will change that, upgrade the wear quickly. Yeah, I want not to believe this wear can cross. So let's see the procedure today. Next. Yeah, this is XTA wear, but it's not good obviously, so we change it to PAD 200 next. Yeah, I think this is PAD 200. PAD 200 can cross the distal RCA, and using the retrograde angio, see the tip is not bad from the different view. Another next one, this RAO and this cranial. And you see the tip of the part 200 is looks good. So we go forward. Next. Yeah. Is that using we see the different view to test the distal. And next. And for this one, I think the distal may be good. But I'm not very sure about that because this case is a previous failure cases. So maybe we just track the last time the wrong way. So we used Carvel.
Carvel.
Yeah, to a dual lumen catheter to try to. We change the workhorse wear. The next one. Next one. Next one. Next one. Next. Next. Yeah, we used to use a dual lumen catheter and we try to wire in the PDA, but it failed. It's not work. So we try to use for this time. I used the iris. We used iris to check the first wire crossing to from distal RCA to PLA to see what's the wire position. Next. Next. Yeah, this is this dialect. Next.
Next.
Yeah, we see the. Can we see the iris? The first iris.
Iris pertama.
And we put the iris into the big screen. Yeah, the iris cannot cross the proximal cap, but from the tip of the iris catheter, we can see the wire is in the true lumen, but with very severe calcium at the beginning. This is the first.
Yes,
this is the first run.
The first slide.
Did you do a distal tip injection to see the distal vessel early on?
Yeah, no, we do not do the tip injection because I'm not confirmed. I'm not sure the tip. This is not the first one. The first, please see the first run.
First run pertama.
Yeah, this is the first run. This the iris catheter for this time. Iris catheter not cross the lesion, but at the tip of the proximal cap, we confirm that proximal cap is very calcium, but the wire is in the true lumen. So we use the 1.5 balloon to dilate to 8 atmosphere, and we confirm at least the proximal part of the wire is right. And we dilate it more, and then go to the next run of the iris.
Next one.
Yes.
Okay. Yeah.
This yeah. So, but for this run, it's not good. Yeah. But this is from the PLA. Yeah, the PLA we can see can we stop? From distal. More distal. From the beginning. Yeah.
Okay.
We can see the true lumen is in the 6 o'clock. Yeah, comprised in the very small space. The average catheter is in the subintimal. And play. Yeah. Yeah, from proximal, we can see the true lumen in the 6 o'clock, and then the PDA coming. Yeah, the PDA we can see clearly. Yeah, the catheter, but in the for this part, for the distal RCA is still good. The where the iris catheter in the distal RCA is in the true lumen. Yeah, but maybe not the lumen, but in intraplaque for the distal RCA, because distal RCA is a big vessel. The iris catheter is intraplaque. We still have intima between the between the PDA and the distal RCA, so the wire cannot penetrate into the PDA osteum. Yeah, so that's what do we do now? So what's your comment from the panelists?
Dr. Shafiq, any comments from the IVUS imaging?
All right, excellent job by the operator. Well done. So basically, from the IVUS, the operator mentioned, the distal bit is actually intraplaque, or it's not in the true lumen. When it comes the definitive management afterwards, i.e. whether we're going to put a stand in or a DCB. This is very vital, very important.
1,000.
In my practice in Malaysia, we use a lot of DCBs, and the most important things and rules for DCB use is we have to make sure that everything is intralumen. So if we plan to treat this with DCB, perhaps you need to rewire and get into the true lumen, the whole RCAs into the PD. But if we plan to put a stand in, I guess re-entry is adequate. Yep, that's my 2 cents.
Prof. Tan, do you have any comment on the IVUS?
Yeah, now that the IVUS tells me that we are in the false lumen, perhaps a double lumen catheter with a second wire to redirect into the true lumen would be helpful here.
Dr. Yamin, do you have any comments?
Yeah, I think basically I am agreeable with Prof. Tan's opinion. So we try to rewire with the double lumen catheter. I think most likely I predict it will be successful because I think it's quite easy because we can just try to redirect the wire to the true lumen and then proceed accordingly.
Okay, Dr. Song, Dr. Arif, can you explain the progress of the procedure?
Yeah. Thank you for the panelists. And for this time, because this patient have some interventional septal channel, so I try to wiring the septal and use the PDA wiring cross the septal channel now. And because if the septal channel, if the retrograde does not work, we can, as the recommendation of the panelists, we can do the antegrade again and use the dual lumen catheter to wear the, using the parallel wiring to penetrate the PDA. But if both failed, unfortunately, maybe we can investment for this procedure and using the drug coated balloon maybe. And for this time, I want to try the septal first. And for the septal channel, looks good, but we try several times using SO03, and but the tip is not so good connection.
So what wire are you using for the retrograde, Dr.
Yeah, this one. First one is the Sion, and second this wire is SO03.
Sorry, can you repeat that again, Dr. Arif? What wire is in the antegrade?
Yeah, for the retrograde, the first wire was Sion, and then Dr. Songlei changed to SO03. And now we use the SO03.
Yeah, this is SO03.
SO03 in the retrograde. Okay. In the antegrade, still pilot?
Antegrade, we can to work cross wire is Sion blue.
Sion blue.
All right.
Yeah. But the distal wire is in the subintimal of the PLA. But the distal RCA is good, I think. But at the bifurcation, I think at the bifurcation, it's go to the subminimal space.
Okay, in the time being, if I can ask Prof. Tan, how do you decide between starting with talking about wires, right? How do you decide between starting with a polymer jacketed wire versus an intermediate or high penetration wire for us who are still starting learning a CTO intervention, Prof. Tan?
The banding of the mid of the.
Many people have to develop their own algorithm as they go around. So I think for integrate CTO, for a start, if you can vaguely see some kind of track or short blockage, I think XTA is oftentimes a recommended approach. Once you can't go through with a polymer jacket like an XTA, I would suggest, and this is where wire escalation come in, or this is where you want to consider something that's stiffer. And my personal preference is to use Gaia next. Just because it's got better control here, so I will escalate to Gaia 1 and 2, and then as you go along. So again, if a Gaia wire is not successful, this is where I will then escalate to finally the Conquest series of wire. So it's a algorithm that everybody will have to practice and how to get familiarized with it, different wire properties.
Dr. Yamin, what tells you it's time to stop with the first wire and stop manipulating with that wire and escalate to another wire? Do you have any tips and tricks for that?
Because it goes with the experience. You have to practice with the tactile sensation as well. So when you cannot push further and the tip of the wire tends to bend as you push gently, then I might decide to escalate the wire.
Okay, and maybe from Prof. Tan, in your experience, I know you've done more than 10,000 PCI. So what is the biggest mistake, especially for early learners operators, make during the first 30 minutes of a CTO case?
One of the
audience, you can see the imaging quality of this DSA machine. The septal channel is clear.
Okay, maybe we can hold that thought for a while, Prof. Tan. Dr. Arif, can you tell us what's happening in the cath lab?
Yeah, we only recently performed the tip injection to make sure the septal collateral again, and we want to try to serve again with the SUO 03. Kasih ke atas tadi. Udah ya, oke.
Okay, so Prof. Tan, coming back to that question, whilst they are dealing with this issue, so what is the biggest mistakes operators make during the first 30 minutes of CTO case usually?
I think to do any CTO, first of all, the most important aspect is to actually analyze the images. I think this is where most people don't spend enough time here. So I think planning for the entire procedure is the key here. And so if you can do all the images such as CT scan, or particularly for those very complex CTO, that will give you the additional information. Once you have started the procedure, I think this is what Dr. Song has done. You always have to do a contralateral angiogram shot. A lot of time I see people doing CTO and then they just do it by one angle and then they don't do a contralateral shot. You are not set up for a successful CTO or PCI here. You don't have a contralateral shot here. Because what he has just done so far is that he's trying to avoid causing a vessel injury to the occlusal segment here, avoiding tip injection, using imaging to guide it, to make sure that he's in the right lumen, and then gently escalating the wire without resorting to stiff wire very early on. I think some of us do grow a little bit impatient with CTO. And
Patience is one of the flaws of some early cardiologists like me, probably. But I think with experience, we gain more patience. We learn from our mistakes and all. Do you have any learning points?
This is Yamin. I would like to ask one very important question. So what is the parameter for you? What tells you when to stop?
So integrate. Dr. Song, right? Yeah.
You mean the antegrade when to stop?
No, Dr. Yamin is asking Prof. Tan's question. What are the marks when we know we need to stop?
Yeah, based on our algorithm, not only from the Japan, the Western hybrid algorithm or the AP CTO Club algorithm, we set stop criteria. If the procedure time is longer than 3 hours, and the X-ray exploder is huge, and the contrast using is 3.7 times of the EGFR, and so the progress can we have now further progression, so we need to stop. Yeah, but for this case, I think we still have opportunity to cross the septal channel. If this channel is not good, we can try another one. And if it also not work, we can use back to the anti-grid using the dual lumen catheter-based parallel wire. And if it also failed, we can use ballooning the distal RCA and do the investment. I think this is my strategy.
Prof. Tan, do you have any suggestion?
I think that guidelines is a reasonable one, but you always have to contextualize to the patient. So if you are making progress and so forth, sometimes you push a bit longer. But if you are making no headway or even 1 hour might seem too long already. But I think here certainly there is a opportunity for retrograde crossing into the collateral. So it's worthwhile keep investing.
Okay, I have to say the image quality is very good. Josh, can you explain a little bit what's the difference of this new noise-free image with amongst other cath lab system?
No, let's try another septal channel.
I have to say that it reminds me of the simulating machine that I used before, where there's absolutely no noise and just the artery.
Yeah.
Yeah.
This is a noise-free technology. We actually leverage the intelligent algorithm to remove almost 100% of the noise from the image. Then we can reduce exposure. And today, actually, we invited the CEO of X-ray business, Dr. Jun Xiang, on the stage. So maybe Dr. Jun Xiang, can you explain how you make it? I realized that this technology has been released into the global market since the beginning of last year, and we see a lot of lab cases from China, from Uzbekistan, and here in Indonesia, we also see very clear images. How you make it?
Well, okay, so it's a very complex technology, questions. So it's very difficult to answer this question in a short time. So, but in general, we reduce the radiation dose by 70%. We still improve the spatial resolution by 57%. And 4 times of the signal-to-noise ratio improvement. And how? In general, we just reveal the tiny details by, reveal the uncovered details by noise. I mean, many details just covered by the noise. After we remove noise, we just reveal the details. In general, we don't improve the resolution physically. We just recover the details on the image in general.
And Dr. Song and Dr. Arif, how do you view the system of Yuanjia Viva during the procedure?
I think the systems work very well and give us clarity.
You can see the imaging quality of this tip injection.
Does this system come in a biplane system?
We can pull back a little.
So are you going back to integrate the so? So still trying to...
No, not yet. I think now the time I try this channel. As you think we have turned another channel.
Another channel, okay.
I think maybe this. I hope this works.
Okay, maybe Dr. Jun, can you explain a little bit how the technology in this CAD/LAMP system, aside from noise-free, how it helps doing this CTO case procedure, the AI in the system? Is there any benefit of the AI in this system for CTO case? John?
Yeah, maybe I can answer this question. Actually, we have several AI features to empower the CTO cases. For example, the noise-free, we can reduce the dose by 70% of exposure. And also, in noise-free technology, we also have AI coronary enhancement. So in that technology, we can dilute the contrast media by 50%, but even you can see very clear coronary angiography. So actually, Professor Song with Professor Zhang Jianming in China, they performed a clinical trial last year to validate the contrast media use. The result is so promising. So after dilute by 50% of the contrast media, the image quality is still very good. And the QCA don't see any significant difference between the 100% concentration and 50% of dilution. That's the AI. And also, we have AI to use like a coronary dynamic roadmap to see the collateral arteries. For example, in this case, if we have a dynamic coronary arteries roadmap, we can to review the collateral from left side to the right side to see a crossover between the right side and left side. So this is another AI features. And also we have UAngio FFR, we call it UFFR. It's an automatic angio-based FFR. I will talk about it later during the lecture. And this technology was also co-developed by United Imaging and Dr. Song Lei together since 2 years ago. So the primary result is so promising that our retrospective study confirmed that the accuracy of automated UFFR compared to wire-based FFR is around 85 to 90% of the accuracy compared to wire-based FFR. So our technology by AI actually, our concept design actually to lower exposure, higher accuracy, higher precision. So yeah, and any comments from Dr. Jun Qiang about the AI features in the complex PCI?
Okay, in my eyes, the most important thing actually is, when we just remove the noise, we can see the collateral vessels. That's the most important, the contribution to CTO. But in general, and I think that the dynamic roadmap of coronary is could be very useful.
Looks good. Not easy to cross.
So is this a biplane electric system here in the lab? Or is it a single plane?
Okay, I think they are concentrating still on the crossing of the CTO. Any comments on the procedure progress so far, Dr. Shafiq or Dr. Bakhtiar? Any suggestion for the operators? Maybe Dr. Bakhtiar first.
Yeah, I think, since the initial collateral attempts seems a bit difficult, probably, yeah, I will consider to find another retrograde approach. In west vessels, and then if that's not successful, then yeah, no choice. Probably we need to go back intricately for the double lumen intricate approach. I think that's pretty much the option that we have.
Dr. Yamin, can I ask you a very general question? Since I realized that the patient is still very young, 34 years old, and we can see the triple vessel diseases, especially for the right coronary total occlusion. So can I ask, what's the pathogenesis of CTO, especially for this kind of young people? Pathogenesis, pathology.
Well, I think, as we know that now the coronary disease in young age are increasing in terms of incidence. I think lifestyle is, of course, the most prevalent cause now. I think many studies have shown that. So lifestyle, I think in this patient, I'm not aware whether the cholesterol level is high or not, and I'm not aware whether he smoked or not. I think lifestyle is the most prevalent key factors recently. I think has been shown by many studies. So at this young age, I think after we successfully revascularize this patient, so please do not disregard the patient education to keep his lifestyle better and maintain for the rest of his life.
Oh, yes. Some channel.
Thank you. So, Professor Tan,
But
do you have any comments on
Okay,
that? Because it's very still young people, and do you have any indication on that?
From the back. Okay, from the back.
Can you hear me?
Yes, we can hear you clearly, Prof.
Okay, good. I think most of the times, I think we all agree that chronic total occlusion occurs as a result of some form of rupture or erosion followed by some kind of thrombotic occlusion, which may be subclinical, and then it organizes and mature into a fibrous and oftentimes calcified scar tissue over weeks or months. And so this is a chronic process that we all know comes from an atherosclerotic process, which is a progressive condition. So we heard about it being driven by pulmonary risk factors and so forth. But essentially, this will be the mechanism of CTO that we are dealing with here.
Okay, I understand Dr. Arif did a CT scan of this patient yesterday. Maybe Dr. Arif can explain a little bit if the calcification is large burden or is it just small burden calcification, Dr. Arif?
Okay, so we did the CT scan 2 days before, and we see the calcium score is quite high, more than 500, and also in the CTO area, in the mid-distal RCA, there are a lot of calcium plaque there, and also we can see from the previous IFUS on the distal RCA, it's also heavily calcified. In some area, there is 360 calcium plaque.
Okay, thank you, Dr. Arif. I think this is quite remarkable, isn't it, Prof. Tan? This is the young guy, 34 years old of age, but already have a 500 calcium score. Do you think, is there anything that could propagate this young guy of 34 years old to have this large calcium score?
Just tell you that he's got underlying accelerated atherosclerotic process. You all know it's a combination of genetic and environmental factors here interplaying. So there is underlying genetic predisposition here that got expressed very early on in life because of its lifestyle.
Anyone?
One would in the young CAD patients over here now, we're doing a number of studies as well to see whether there are any other cardiovascular enhancing factors that perhaps may cause this accelerated atherosclerosis, such as your lipoprotein little A. Now people go for metabolic associated steatotic liver. So we're looking at a whole great branch of inflammatory markers to see whether there are something else that is operating in this young patient.
Thank you, Prof. Tan. Dr. Shafiq, do you find a lot of young MI patient or young CAD patient in Malaysia as well?
Yep, certainly. I think the trend is increasing now. We did, because I'm working in university hospital as well, so we did research and data collection on patients below 40 years old. And the thing that we found, these people, most of them, they smoke. And at the same time, they have abnormal lipids, dyslipidemia. Some portion of them are known to have very high lipids, which probably being diagnosed with familial hypercholesterolemia, which is underdiagnosed. But yeah, for the past few years, I think I tend to see more less than 40 years old coming in with STEMI and non-STEMI. Perhaps lifestyle, stress factors, like Prof. Tan mentioned, as metabolic component as well. So a lot of things going on. And this kind of patient, this patient, 34 years old, very young, diabetes, not sure whether it's a MODY type of diabetes or type 1 diabetes, not sure. And Prof. Yamin did mention about we are a bit unsure about the lipids control for this patient. All of those things perhaps can contribute to all this chronic inflammation process, which is slowly increasing the atherosclerotic plaque to a point that it's completely closed, like CTOs, and become more calcified. And it's difficult to pick up early because the body tend to develop collaterals and they become subclinical. So only when they exit themselves, they start to feel symptoms. So people who don't exercise, who sedentary lifestyle, perhaps they don't get the symptoms earlier. So that's the challenge that I think all the cardiologists in Southeast Asia is seeing now.
And given that we know already that this calcium score is about 500, would you change your wire strategy, Dr. Yamin?
I think a good question, a good point made by Dr. Indah. I think so looking at the calcification, especially in the CTO area, I think it may change and redirect your strategy accordingly. I mean, you need to escalate the wire early on. Once you feel that in the tactile sensation, so your wire cannot cross easily. I think personally, I would like to escalate further.
Escalate earlier, you mean?
Yeah, earlier.
Okay. Dr. Shafiq and Dr. Bakhtiar. Dr. Shafiq first. Would you do it differently?
Yeah, no, I totally agree with Dr. Yamin. CT scan help us a lot. Yeah, so tell us how bad the calcium is, how severe the calcium, the plaque is, because if the cap is heavily calcified, you probably want to escalate to heavy tip wire straight away like Conquest Pro to cross the calcified cap, and then you can de-escalate the wires afterwards. So why it helps with wiring, number one. Number two, once we cross, that it doesn't stop there. Yeah, so we need to get the microcath across the lesion, and by knowing that the patient has heavy calcification, it helps us to decide which microcatheter we're going to use. So perhaps in a heavily calcified lesion, then we tend to use Corsair Pro or Turnpike, where we can do a bit of maneuver to cross the lesion. Yeah?
Dr. Bakhtiar?
Yeah, I think because sometimes we want to know before we attempt to puncture the CTO cap. So most of the time we will like to know the feeling. So I think probably the reason Prof. Lee Song attempt XTA first, probably because we want to get the tactile feeling first. Then I mean, but if of course as we know, the CT scan finding of high calcium score, probably the length that we try to attempt, we probably need to make it less. If we cannot pass through, probably we need to escalate further with a higher tip wire, such as Gaia and so on.
Okay, let's go back to the cath lab for a while. Dr. Arif, could you explain what is going on in the cath lab currently?
Yeah, because we try several channels but not work. It looks connected, but in the distal we see a lot of microvessel. See the last angel in the distal, the previous one, the previous one. Yeah, this one. We can see the distal PDA visualized, but we can see a lot of microvessel there. So they're not truly connected. The SO03 wire cannot cross this one. I tried several times. So now, Professor Chen, what's your suggestion for this step-toe?
I think you have tried hard enough in trying to find a collateral branch retrogradely. So maybe we will consider parallel wire double lumen to go back to integrate again. But
yeah.
Know where
but now I try to use a back to the antigrade approach, dual lumen catheter.
Sasuke.
So CTO PCR is a very dynamic situation. You don't want to stuck in a failure mode, change if things are not working. So in the one of the things that
when we
quite
back to
interesting.
the integrate, what's the we want to penetrate the PDA. What's your suggestion for the penetrate wire?
So it's going to be your personal choice. But I always use a Conquest Pro for very calcified. But for calcified proximal cap, but just making sure that the direction is correct.
Okay. Yeah. Thank you for your suggestion. I try to use the Gaia search first, and then we go to the Conquest.
Gaia search.
AP cranial.
AP cranial.
Can I ask a question?
Oh, yes, go ahead.
I think
it's
this
an
is
open
for,
forum.
Yeah, this is for Dr. Yamin and Prof. Chan and Dr. Song as well. So crossing a CTOs, is there, do you guys use IVUS guide to cross the CTO?
You can possibly use it if the vessel is large enough, particularly at the ostium. But here is a very, very distal CTO they're dealing with. There's actually not much of a depth. So you can't actually put an IVUS catheter and then try to cross it. So you can only guess from the previous images the location and try to direct the wire in the manner that you think where the truth will be. The existing wire will provide you with a guide as to where not to go with the new wire.
Yang ada anggilnya.
Yeah, for the hours guidance, because we use the dual catheter, and our catheter cannot go into the 7 French catheter. We have to use the 8 French catheter. But for the if you use the single lumen catheter is available, I think.
Dr. Sua, what do you think if we approach this at this stage using the same technique? So we modified the plug by small balloon at the main PL branch, and then it may modify the ostial plug at the at PDA. So I think this may help at this stage as well. What do you think, Prof. Tan? It's the same approach.
Yes, we have the lattice ostium of the distal RCA.
Yes, Prof. Tan, go ahead.
Try not to balloon first unless I'm quite certain it's worried that the ballooning might just alter the anatomy here. So I try with the parallel wire first and see how it goes.
Parallel wiring technique first. Okay.
Yeah.
Yes.
Okay, whilst we wait for progress on the cath lab, we'd like to have a short break of a lecture here with Dr. Jocelyn. He will present about noise-free angiography system EU Angio Aviva CX. So please join us to welcome Dr. Josh, please.
Thank you, Dr. Inda. Can you share the slides? Okay, dear Professor Tan, dear guests from the Southeast Asia, this is Josh from United Imaging. I will take like 10 minutes to briefly introduce the noise-free technology from United Imaging. So as you already, I control room, I cannot use here. So as you already seen during the broadcast, the UNGO Viva system is very clear. So we call the system is a noise-free system, And we have three key features in the noise-free system. The first one is noise-free, to see more, exposure less, and we can improve the signal-noise ratio by 4 times, while we can reduce 70% reduction of those. And then we have a AI-enabled hands-free. So we leverage the AI cameras as well as the voice control technology to make system hands-free. So during procedure, actually, the physicians can use like a high vera, go to heart position, go to like a cradle arteries, something like that. So we can use a voice-free to control the gantry move. And then we leverage the 8-axis city mounted robotics to make the system move freely, especially for some complex procedures like a TAVR. Here I showed a slides by leveraging the AI-empowered efficiency. So in left side, you can see the 3 cameras. We installed the 3 cameras on the top of the floor. Then the cameras can capture the 3D of the environment in real time. For example, you can see the patient, you can see the physicians, as well as the gantry, the table in the cath lab. Then the system will know where the specific organ and the specific place of the cath lab it is. And then by leverage the voice control system, then you can use the high vera to control the CR move, to control the angulation about the system. Here I have the step.
Hi. Go to gate position. Patient hand position center system. Show all images. Place series 5. Laser on. If we walk over here, we can see that the laser light is on. Laser off. Go to left radial artery. Patients on the radial artery position sent to the system.
Once you give a command, just
LAL 20 degrees. LAL 20 degrees is sent to the system.
Here's a
Stop. Center rect 1.
So you also can use voice control.
Change layout to 4.
Play the series to set the reference.
And one of the best features of all, play music. Which song would you like to hear? The first song.
It's very attractive features in Western countries. And as we have already discussed about the noise-free, so noise-free is an AI-based denoise technology. So we leverage the burst denoise technology, which was invented by Google many years ago, and has already been very commonly used in your cell phone. And this technology actually is by using the spatial temporal plus AI extraction features to separate the signals and the vessels. Then we can remove the noise. As Dr. Jun Xiang said, that in this technology, what we did actually is remove noise, remove the fog on the environment. Then we can see, review the unseen vessels. So in this case, actually, this is a total same raw data. After noise-free processing, we can see much more clear collateral arteries in this CTO case. So that's why we can see very clear collateral arteries during today's live show. And under the normal angiography, for this case, we can see very clear on the stent structures. So by using this technology, actually the use stent life or use stent is not needed. I mean, even using the normal angiography, you also always can see the stent very clearly. And the noise-free angiography actually was released in the beginning of last year, in February 18th in Shanghai. The first live case was done by Professor Jun Boge from Zhongshan Hospital. This case was really complicated as today's. So the procedure was performed in around 2 hours. And in this case, we can see very clear collateral arteries under low-dose angiography. And also this is the same with today. It's a right coronary total occlusion. And the Professor Jimbo tried to integrate and retrograde CTOs. And in the end, the angiograde was success. Then the right coronary artery was opened in that time. And Professor Ge's team also performed a clinical trial last year after the first case was performed. They compared the noise-free angiography dose level compared to other conventional angiography system. So the group A, the blue group, showed the dose level in simple PCI or complex PCI, for example, CTO. We can see that the noise-free in simple PCI can reduce the dose up to 62%. And even in the CTO case, we can see the reduction of dose up to 73%. It's so promising. And in the lower of the slides, you can see the image quality compared different of the angio system. The group A shows very clear of carotid arteries. And in group B, C, D is a conventional angiography system. We can see very clear, but compared to group A, it's still like in some noise on the images. And the data has already been published in the Circulation Cardiovascular Intervention in the last quarter. And as Dr. Inda asked how AI helps in the CTO cases. For this technology we called noise-free AI coronary enhancement technology, we can enhance the coronary by AI and then result in like a 50% of contrast media dilution during the procedure. A clinical trial was performed by Professor Song Lei and Professor Zhang Jianming in China last year. The study showed a very good correlation between the 100% of contrast media versus 50% of contrast media. The result has been reported during the TCT Congress last year in San Francisco, the US. And we not only improve the image quality to reduce the exposure and also the contrast media, but also we are introducing a AI-based precise PCI solutions for the complex PCI. So we also have a dynamic coronary roadmap. We also have a use stand access like a stand boost during the procedure. We're also providing the physiology and the intravascular imaging co-registration. For example, the integrated auto FFR is, we are the first one to integrate the auto FFR into a coronary. So once you get an angiography, so you will have a FFR result immediately, 10 seconds after the angiography. So we also can co-registrate the IVUS and the OCT during the PCI to see the vessels. So we have partnership with Boston Scientific and Insight Lab Tech and also Abbott on these intravascular solutions. So I will talk a little about the FFR. So as you always know that the stenosis doesn't equal to ischemia. So results shows that 28% of false positive and 13% of false negative when you are using the QCA as a gold standard. So since 2011, the guidelines has already suggested the physicians by using the FFR, wire-based FFR. But even the physiology is crucial, but with still very low penetration in the world. That's why, because wire-based FFR will time-consuming and costly in coronary, doing the coronary physiology. So that's why we developed a angio-based FFR. So from invasive FFR to non-invasive computed FFR has already have a lot of clinical evidence. The wire-based FFR, for example, the FAME studies, series studies, published a lot of paper in the New England Journal of Medicine, Lancet, and also the angio-based FFR also published a lot of paper in the Lancet and the New England Medicine. Since 2018, more and more guidelines suggest to use angio FFR to guide the intermediate lesion of coronary stenosis. For example, in 2024, ES guidelines suggest to use the angio FFR or QFR or there's some other virtual FFR to guide the intermediate lesion of coronary. And the Chinese guidelines and Japanese guidelines, Asia Pacific expert consensus also suggest on this. And what is our concept design? Actually, we integrated auto QCA and auto FFR by AI. For example, during the procedure, when you get a coronary angiography, the system will do the automatic keyframe selection by AI, and also do the coronary tree contour extraction by AI, and then do the automatic FFR calculation by AI in 10 seconds. In our system, we trained the system by more than 10,000 cases in total. For example, 4,000 cases to train the keyframe selection, 8,000 cases to train the contour extraction, and 2,000 cases to train the UFFR. And here is a video showed the process when you use a UFFR during the procedure. The only thing the physician should do is to do the protocol selection and coronary angiography. So the angio FFR will be generated by the AI automatically, and also the QCA and the virtual stent as well. So here is a real clinical case in hospital. We can see the integrated real-time UFFR versus wire-based FFR. This left LAD intermediate lesion with like a 70% or 80% of stenosis by your eye estimation. And by using auto angio FFR, we can see the FFR value is 0.89, is negative. We get the data in 10 seconds, but we also do the wire-based FFR. It's also 0.89, totally the same with UFFR. The wire-based FFR takes around 10 minutes to get a result. Here is a clinical case from Fuai Hospital from Dr. Song Lei's team. So this case is right coronary, like a diffuse or tandem lesion. We can see like 80% or 70% of lesion. And doing the physiology of angio-based FFR, we can see the UFFR value is 0.77. It's a positive. It means that we should place a stent on the right coronary. And afterwards, physicians also performed a wire-based FFR to confirm the result. The wire-based FFR is 0.75, very close to the angio-based FFR. And the angio-based FFR also give a suggestion to place a stent like a 3.0 diameter with 38 millimeters length of the stent. And physicians just take this kind of solution. And after the procedure, we can see the UFFR after procedure is around 0.92. And the wire-based FFR is also 0.92 during the procedure. So in this case, we can see very clear that UFFR is very, very useful during the procedure to for example, to diagnose the functional stenosis, and then to give a virtual stenting to suggest how big size of the stent and how much size we should put in the vessel. So in summary, the UNGR Viva system is like a 3 key advantages: noise-free, hands-free, and move-free. And then noise-free significantly reduce the radiation exposure and the contrast media using during the coronary intervention without compromise in image quality. And then auto FFR integrated in real time of QCA and FFR enables fully automatic quantitative assessment of vascular morphology and the physiology, supporting a standardized and precise PCI. But the UFFR is still under registration by MDR, so it's not available here in the Southeast Asia so far. But we're going to get the clearance next year, and we'll have installed in this region. Thank you so much. And any questions from the audience?
By the way, for this integrated FFR, and I call it personally is instant FFR. That means after you get angiogram, you will get FFR. And the idea actually was in a coffee break. with Dr. Song in Shanghai. I hope we can have this kind of ideas together to make life easier, make the procedure easier. Yeah.
Do you have a comparison study between, the wire-based, like IFR? Do you have a RCT?
Yeah, that's what we are doing with Dr. Song. Yeah.
Okay, can we back to the first layout, please? Prof. Tan, do you have any question for this particular presentation, Prof. Tan?
I personally think that physiology is going to be the future of PCI. And physiology is not just going to be invasive, but it's also going to be angiography as well. But I like to look upon this angiography FFR as complementary to what we have in our cath lab using wire, because sometimes there are situations where there are limits to angiography-based FFR as well. Things like very diffuse lesion, or things like ACS culprit lesions where you really don't know about the functional significance and so forth. But certainly it is a very promising technology for assessing whether you want to do PCI or not for a lesion like left main or side branches and so on and so forth. So I think it is going to be something that is complementary to what we have in our lab. We just need more study to tell us whether this angiography-based FFR is just as good as invasive FFR because of this conflicting data that we get from paper 1, 2, and 3.
Yep. Thank you, Prof. Tan. I note that you have to go in a short while. So before you leave, this is one of challenging cases that we have today. What do you think is the single biggest learning point from today's procedure? If you give us your 2 cents before you have to go and leave us. Thank you, Prof.
I have to say that this is indeed a case that is really meant for Master of CTO, and Dr. Song Lei is certainly one of them. And he has demonstrated that you have to keep in your sleeve a whole armamentarium of skills and devices and back up with experience and good judgment. So you don't stay in one particular mode of failure. If something doesn't work, you switch your treatment strategy. And if you think that you have tried your best and it's not going the way you want it to be, there's no shame in not doing a successful PCI. It could be investment strategy for the next time, or we always have a medical therapy to back up here, because this patient has already benefited from a PCI to his LAD answer.
Thank you so much for your time, Prof. Tan. We would like to extend our extreme gratitude for your presence in today's education session. Thank you, Prof. Tan.
Thank you, Prof.
Have a good day.
Okay. Bye-bye.
Okay, let's go back to the cath lab. I see we have wires in the RP and PDA already. Dr. Arif, can you update us on the progress in the cath lab, please? Or Dr. Song Lei?
Okay. 6. Yeah, thank you. 6. We have follow your suggestion. Okay. We use the dural lumen catheter penetrated the PDA and success with gathered where. And we have checked the errors I can show you later. 16? 16. 16. Down. 20. Down.
Congratulations. We are looking forward for the updates on the step-by-step procedure.
20.
As the eager panelists looking the pre-dilatation. Any comments? Any prediction on how Dr. Song Lei did this before he explained himself? Dr. Yamin?
So I think based on the IFS finding, we could just whether we need to stand up to the distal RCA. Personally, I think the distals, if the vessel size is quite big and then the recoil after the balloon is less than 30%, maybe more than 30%, maybe we need to stand that part. Otherwise, if the ostial of the PDA is also diffuse disease, personally, I would put the CB there and then stand all the way before the bifurcation up to the CTO segment.
So no stands to the PL branch?
I don't think so. Let's size the vessel first. But personally, I think if it's too distal, and after the balloon, the collapse is less than 30%, we may need to just put DCB at distal PL.
Okay, we have the DCB experts on your left-hand sides. The two Malaysians, can you give a comment on this in this case?
Yeah, I mean, we are not expert, but we have been using DCB a lot in our center at least, and also if in the east part of Malaysia also the usage of DCB is quite huge in terms of especially in this kind of young patient who has diffuse disease, CTO, and then sometimes you want to if the patient needs to go for another procedure in the future, then DCB will be the way to go, particularly in this young 34 years old patient. So I'm interested to know how did Prof. Young approach, I mean, managed to pass the CTO cap, whether he used a parallel wire that managed to pass through the CTO, or he used the double lumen catheter with integrate wiring. So I think probably he managed to pass through without the need to re-enter the double lumen. So interesting to know what actually happened.
So are all of us, I think. Before that, let's hear from Dr. Shafiq. What do you think? Can you predict? This is like World Cup final, so you try to predict what's the strategy. Yeah.
Okay. So well done to the operators. Managed to cross the lesion. I'm not sure how Dr. Song's practice in China, but like Dr. Yamin has his own plan, Dr. Bahtiar has his own plan. But when it comes to diffuse disease, CTOs, and of course nowadays we tend to keep as normal as possible, leave nothing behind. So that's a term that we normally use when we decided to use DCB. Leave nothing behind, no metal, nothing. Why is it important to leave nothing behind in a CTO? Number one, in a CTO, because it's been blocked, fully stenosed for quite a long time. There's a tendency for negative remodeling. So if you put a stent in, then when the vessels healed, then might grow up and increase in lumen size. Hence, the lumen become under malapose. Yeah, that's number one. And of course, number two, putting a long stent in, we know from the studies, it also increases risk of ISR, in-stent restenosis. And number three, we try to keep the vasomotor, the physiology of the vessels as normal as possible. If you put a stent in, of course nowadays we have a special stent when it becomes uncaged after 1 year. But having a metal around wrapping the vessels, it tend to affect the vasomotor and physiology of the vessel itself. So by having a DCB, if possible, that would be a better option. So how do we choose? Like I mentioned earlier on, number one, we have to make sure that the wire is intralumen. You cannot go, underneath a plug and so on. So it has to be intralumen, and for that we have to have IVUS assessment, like what they're doing now. If we confirm it's within the lumen, then perhaps, if not so much of recoil or significant dissection, then perhaps there's a chance to put a DCB on the vessel itself.
What about Dr. Yamin's concern that the recoil is above 30%? Would you still put in a DCB or would you stent otherwise?
So depend on whereabout the lesion is. So if it's a proximal RCA, a proximal LAD, then I'm a bit worried and concerned. Distally, I'm trying to be a bit more relaxed and then tend to DCB, but we do have FFR, UFFR, FFR, QFR, if you look at the algorithm, so if the FFR is less than 0.75, you can actually allow DCBs. But for small vessel, this a bit distal. Sometimes, even though there's, it's a bit more than 30%, but I still give the benefit of doubt to the vessel and put the DCBs.
I think the importance is the lesion preparation after we cross the lesion. So that's why when we consider DCB, the lesion preparation is very important. So sometimes, of course, we use most of the time according to the IVERS. So we need to use the specialized balloon, cutting, scoring balloon. And sometimes some people pre-dilate the lesion even more to prevent, in terms of length, let's say some people go to even half second or 1 minute to make sure that the recoil is the chance to recoil is less. Therefore, the chance to use a DCB is higher as regards to DCB preparation.
Typically, I use DCB for smaller vessels, but I understand that colleagues in Malaysia use also in the larger vessels and sometimes even in CTO lesion as well. What's your experience? If the patient came back, does it still patent for the CTO PCI with DCB, or is it negative remodeling, the recoil came back?
I think for CTO, we already have good data, good research paper, and some of it was done in Malaysia with a collaboration with Prof. Shin in Korea. So did a DCB in the CTOs with good outcome, at least non-inferior to the DES. I think for large vessels, it's still undergoing and collecting. Still monitoring the outcomes, but of course, in certain case, DCB is more preferable than DES. And our own experience in our own centers, so far it's quite good, especially when we use a paclitaxel-based DCB. We can see the luminal gain whenever we call the patient back for a stage PCI or for a relook after about 1 year.
Okay, now let's go to the cath lab. I think they, settled down a little bit. They did IVERS before this. Dr. Arif, can you hear us? Dr. Songlei?
Yeah, we can hear
Yeah.
We can show the IVERS imaging now.
Before the IVERS, everyone here is very curious on the step-by-step you managed to pass through to the PDA. Can you explain a little bit on that? Thank you.
Yeah, let's see the angel from where we left.
Waktu wire masuk PDA. To the point where we crossed the PDA.
Penetrates the PDA.
Previous. More. Back more. Back. One more. Back lagi. Back lagi.
Yeah, this one. We use the dual lumen catheter, and this is the gaser. This is where we left. And we use the gaser. The first try is we do not shape the second angle. We use the first angle, but failed. So we pull back the wire gathered, and we shape the second angle about 10 millimeter from the tip, and about 30 degree. And then we penetrate the PDA osteum according to the retrograde angiography, and we penetrate the osteum, and we test. Looks not bad, so we go further.
Next.
And this one. I think this one is okay. We test from the retrograde, and it looks not bad. But actually, we finally test the IVERS, it's still not good enough. But from the angel, yes, it looks not bad. So next, please.
Next.
this area from different views. It all looks good, so we go further. Next one. Yeah, next. Yeah, so we using the single. We change to the single lumen catheter, and change to Sim Blue. This under Sim Blue, where go to the more very distal, and we check the errors.
IVUS.
The first run.
Can we enlarge the IVUS, please?
Previous run. Yeah, previous run.
Previous.
Yeah, this one. Yeah, this one we see this true lumen, but actually it's not. The true lumen, this is still not the true lumen. The true lumen is at 9 to 12 o'clock. Yeah, the average catheter also in the intraplaque. I think it's not maybe not so subintimal, but intraplaque at the ostium of the PDA. But the distal PDA is in the true lumen definitely. Distal RCA is good. Distal RCA is in the center of the plaque, but with calcium, lot of calcium. And then we dilated the PDA using the 1.5 balloon and the 2.0 balloon, and then the next run of the errors, please.
Next IVUS. Selanjutnya, IVUS selanjutnya. Okay.
Yeah.
Play.
We can go to every catheter go more distal, and this is definitely true lumen. Yeah. We can see the three layer of the vessel.
Play.
Play, please. And then we, this segment we now this one. After this one. After a sub branch, this is subintimal, and the true lumen is in the 3 to 6 o'clock. And the ostium of the PDA is also subintimal. Also, we looks good from the angel, from different view of the angel, but the angel always tell us the wrong information. This RC is good. Yeah, so that's what we are now. What's your suggestion or comment? I hear a lot about of the drug-coated balloon. For me, I try to use the drug-coated balloon for this case. Not standing. Not only because it's some subintimal segment varying, but also because this is a very young patient, only 34, and we hope to use a drug-coated balloon and maybe try to re-angio after 6 weeks, and we see if the vessel can keep patent, and if the drug-coated balloon is good and the vessel is not so diseased, and we can leave it alone and leave nothing behind. And was a comment from panelists?
Any so I think it's a parallel wiring technique, right? For those of us who are still studying the CTO intervention, maybe Dr. Shafiq or Dr. Yamin can explain a little bit about parallel wiring technique using that iPad. Can we put up the iPad image? Okay.
Could you help to facilitate the pen?
Maybe landscape better, landscape.
It's not good? No, not bad?
Yeah, not bad.
This is the drug-coated balloon.
Okay,
landscape.
Landscape probably better.
The most
longest
landscape.
Rotate. DCP yang paling panjang.
Rotate. Yes. Yeah.
2.0 DCP yang paling panjang.
And after this, Dr. Yamin can maybe explain about your previous proposed technique of the sesame technique, right? Yeah.
2035, okay?
Okay.
Okay, open. 2035?
Yeah, I think because of this is although we can we do the angel again and the final kidney flow is 3, but still we have about I think it's maybe 20 to 20 millimeters subintimal space. So that's why we want to use the retrograde approach. If the retrograde wire can cross, we can avoid this subintimal varying. So, but unfortunately, the retrograde wire cannot cross the septal channel. But finally, we still do this open this PDA. Why for this time I want to use the drug-coated balloon. I think maybe this patient after 6 months we try to check the angel again, and if the vessel still keep open, we can leave it alone. And I think it's better for this younger patient.
Dr. Shafiq, you want to explain a little bit?
Okay, I'm not sure you can see my doodle there.
Yes, we can. We can see it perfectly.
So I think at our issues now, we have a CTO cap, I mean the distal cap at the PDA, osteo PDA.
Yeah.
Okay. Dr. Song already managed to wire down the PDA, but part of the wires went into subintima, so that would be the green wire. So parallel technique is by putting another wire and using the existing subintima wire as a guide, then we use the second wire to actually penetrate into the true lumen. So you can do that antigradely, or you can also do that retrogradely using. So this is a parallel wire technique. Basically, we have to leave the initial wire, even though it's in the subintima, but get the second wire in and try to get into the true lumen. In a big vessel, like my question earlier on, we can use IVUS guided to see whether we can cross into the true lumen. But like Prof. Tan mentioned earlier on, this is a small vessels. At the end, it's difficult to put IVUS to guide us. Dr. Yamin, is there anything else you want to add on?
What lumen catheter do you usually use for CTO cases like this? Any preference?
Okay. This one? Okay.
So most of our patients, they have complex calcified CTOs. So we tend to keep Corsair on our shelf. But we do also have Caravel and Fine Cross for less complex CTO.
Okay, now let's hear from Dr. Yamin about his previous proposed strategy to go to the PDA with the sesame technique. And whilst Dr. Yamin's drawing, in the cath lab, can we go back to the cath lab first?
3040. 40, okay?
Yeah, okay.
Okay, here, open.
Hi, Dr. Arif.
We have put the drug-coated balloon in the distal, in the PDA, from PDA to the distal RCA. Okay. And we also put the second drug-coated balloon in the distal RCA.
For the
distal RCA vessel is very huge, about 3.5.
For the RPL, do you plan to do anything for the slow flow in the RPL?
No, we leave it alone. The distal the PRV is in the subintimal. So we are in the subintimal. We do not. We already dilated the ostium of the PRV using the 1.5 balloon. I think it's okay.
Okay.
We plan to put 2 drug-coated balloons from the PDA to the mid-RCA and check the final flow. If it's okay, we will stop today's procedure and let the patient re-angel after 6 months, after 6 weeks.
Yeah, Dr. Inda, before we go to Dr. Yamin's ideas, so can you, because we already see a lot of angiography and fluoroscope here, how do you think the image quality of the noise-free?
Honestly, it looks like a 4K in my iPhone. It's very clear in the imaging. I think one of the best demonstration for this noise-free imaging would be, unfortunately, the retrograde didn't have the channel that can pass through the PL, right? But if if it was successful, then it was a excellent demonstration of how noise-free technology here can help facilitate the CTO cases, especially with the retrograde approach.
Yeah, thank you. So, Dr. Cairo, how do you think?
I think you have to do another research and trials. See what's the performance of the operator after a CTO complex lesion. The fatigability is core. Because I think for those who've been doing complex case CTOs, I'm sure you tend to feel a bit more fatigued, very tired after CTO because of the exposure to radiations. So perhaps by having a noise free and a reduction in the radiation, so perhaps you get more energy after the CTO. I mean, not so much fatigue after the CTO cases.
The operator quality of life.
That's right. That's right.
That's right. So actually, we in China, actually, Dr. Jun Boge from Zhongshan Hospital and Professor Gao Junteng from Zhongda Hospital, they just initiated a multi-center clinical trial to versus the dose level in real world that across all the most of the type of the procedures, not only PCI but also the taste for the liver, we call the panvascular diseases. So the study will be initiated in early Q4, quarter 4 this year, and we'll have more than 20 hospitals will enroll 2,800 patients in globally, not only China but globally. So we represent of the study committee. So maybe we are so delighted to invite the clinicians from other countries to join the clinical trial to validate the dose level in real clinical world, and also to validate it, just like Dr. Carroll said, that how the noise-free can help the physicians to improve their life. Right, not only for patient life, but also the doctor's life.
So I think we are very fortunate in MRCC's Mangi. It's one of the cath lab that is using this technology for now.
Maybe you can check next.
Dr. Yamin, I believe your pen is down. So can we see Dr. Yamin's image on the iPad, please?
I apologize. I'm not a good artist in drawing.
No. I've seen your singing and it's beautiful.
Not in drawing. Anyway, so the system technique is actually, if you got a plug at the branch here on the in the red color, so if your wire is very difficult to cross, what we usually do is we balloon the main vessels, and then for you to expect that the orientation of the plug that's protruding outside the ostial may change a bit, so it will make rewiring or wiring the branch much easier. So basically we try to change the orientation of the plug, and maybe we may be able to crack a bit of the ostial plug, and then it will facilitate the wiring easier.
Okay. Would you do a pre-dilatation of the mid to distal RCA first to facilitate?
Okay. Yes, of course. Yeah. The wiring. Sometimes the movement of the wire is also limited by the very tight lesion. It's also helpful in the hydrogray.
Okay. Thank you, Dr. Yamin. Okay. I see in the cath lab the catheter is out already. And Dr. Song is out from the cath lab already. Can Dr. Arif explain the end of the procedure, please? Thank you.
Okay. So we did the final NGO, the LAO terakhir.
Can we zoom in Dr. Arif's, please, and the cath?
So this is the final NGO. We see the nice result after the second DCB.
I can change to the...
Sorry, the NGO, please. 1 second, the NGO is not up yet. All right,
we can see now.
Okay, yeah, play. So this is our final result. You can see good TIMI flow across the RCA to the PDA. Of course, TIMI2 in the PL because it was subintimal. But after DCB, there's no significant recoil. So we accept this is quite nice result. And as Dr. Song said, that we will do the repeat NGO in the next 6 to 8 weeks and see if the vessel's pattern, we can leave it alone like this. We hope that the patient will benefit from this procedure, and thank you.
Thank you, Dr. Arif. Excellent presentation of skills. We would like to invite Dr. Songlei from the Cath Lab to go to the 36th floor if is able. And Dr. Arif, please join us after you finish the procedure. Wow, what do you think, Dr. Yamin? So, have you been converted to DCB after this case?
Yeah, I think from this case we could pick up a lot of teaching points in terms of strategy, patient, and knowledge that we have to master to deal with this kind of case. And then we have to know when to stop and also what is the best for the patient. So the center of the procedure is the patient orientation. Patient is still the best, still the most priority, the top priority that we have to put on whatever we do for the patient. So I think what they have done demonstrated all the concept that we have to adopt from this kind of case. Thank you.
Dr. Bakhtiar, what are your key takeaway points from this procedure?
Yeah, so not the key take, but just about the puncture of the CTO cap. So just now, I think the Prof Cheng remove the PDA wire, right? And then the parallel wire is actually at the PLV. So that's probably another technique in terms of parallel. So not parallel in the same what you call that, the subintimal wire, but the parallel wire is at the branches of the PLV. So that's probably another way to try again to puncture into the CTO cap. So I think probably that's another learning point for us to consider. Like Dr. Shafiq diagram, the wire is within the subintimal PDA. But now the Prof removed the PDA wire and then put another wire in the PLV. So the parallel wire is not within the subintimal, is in the new branch.
Yeah.
So
there's always new things to learn in every cases.
Yep.
Okay, Dr. Shafiq, your learning points from today's case.
I think one learning point that we can see from this case is an excellent pre-planning attempting the CTO. We know the CTO is complex. It was attempted before, but was failed. But this time around, they did a CT scan beforehand. They pre-planned it properly. You can see they have all the equipment ready before they attempt to guiding, prepare for retrograde attempt, and then with the dual lumen catheter as well as proper escalation of the wire. So well done and kudos to the team, the operator.
Okay.
And Dr. Junxiang, can you share your ideas about this case? Because it's another very complex PCI and we got a very successful result. Do you have any comments on the case and the take-home message for the angiography?
For me, as an X-ray engineer for more than 20 years, so the only, my feeling is just we need to work harder to make life easier.
And
thank you.
Yeah, and I heard there's a development of the AI in the future, hopefully for multi-plane.
Yes, actually, we also are developing some AI features to make the CTO case more easier. For example, multi-modality fusion. Dr. Junxiang, can you share something not secret about ideas of the?
Was that a secret?
Okay, so.
Let's edit that.
Okay, actually, we will bring something new for cardiology. United Imaging has a 4-dimensional CT scanner. We call it Sirix. Go back to 20 years ago. My dream as an X-ray engineer is to get a 4-dimensional image. Now we make it happen. It's a bumping heart. We all know, the during the structure heart disease, the biggest problem is we cannot see the structure of the heart during the fluoroscopy. We try to fuse the bumping heart from a 4-dimensional CT scanner with live fluoroscopy. That's the idea. And now it will be a joint development together with Zhongshan Hospital. We hope we can invite you to join us to pioneer this new technology. Yeah.
Thank you so much, Dr. Jun. One of the best thing that I feel that working in one of the foremost private hospital in Indonesia is that new technologies, we get to try it first. New toys, we get to try it first. So that's one of the fun thing. And cardiology is never boring. Always advance every year. And there's always new things to learn. And so as we conclude today's live CTO workshop, I'd like to thank everyone for joining us here at MRCCC Siloam Semanggi and those participating online from across the region. Today's case has demonstrated that successful CTO PCI begins with careful patient selection, thoughtful planning, the right tools, and the ability to adapt strategy throughout the procedure. Congratulations to Prof. Songlei, Dr. Aris Sejati, and the entire CAT Lab team on the successful procedure. My sincere thanks also goes to our distinguished panelists for sharing their expertise and valuable insights throughout today's discussion. And finally, thank you for United Imaging Healthcare and MRCCC Siloam Semanggi and the organizing committee and all participants for making today's educational event a success. We hope today's case provided practical lesson for you all. Thank you.
And thank you to Dr. Inda for your wonderful moderator. Thank you.
Thank you, Josh.